discussing the important PYQs of the subject of cons and endo. Hello, myself Dr. Nitin Kararia, and I welcome you all to this session. So I hope I am well connected, both audio and visuals both are okay. And so shall we start with the today's session. The questions are displayed onto your screens. Question number 1. It is asking in a set amalgam mass, the strongest cathodes are okay. In mercury phase, the copper tin phase, residual alloy particles, or the copper silver phase. Strongest cathodes. Now we all know that dental amalgam in the oral cavity, it forms a electrochemical cell and it undergoes electrochemical corrosion. So for the requirement of electrochemical corrosion, we have 4 requirements in the oral cavity for electrochemical corrosion. Means for the material to corrode in the oral cavity, we have got 4 principal requirements. These are, there should be an cathode, there should be a anode. Okay, this cathode is the site of reduction, and anode is the site of oxidation. First requirement, second requirement, third requirement, there should be a circuit for current. For electrochemical corrosion of the metallic restorations like dental amalgam to occur in the oral cavity, there has to be establishment of the electrochemical cell. And the fourth requirement is the electrolyte. This electrolyte, that is the saliva, which bathes the oral tissues, hard and the soft tissues. The circuit for the current are the hard tissues. Both hard and the soft tissues of the oral cavity, they act like circuit of the current for the passage of electrons. Now, cathode is the site where the reduction reaction occurs, and anode is the site where the oxidation reaction occurs. We all know that the material that undergoes oxidation is the material that corrodes. So it is basically the anode that corrodes always. Now the question is asking you which are the strongest cathodes in the set amalgam. Okay, so strongest cathode means which are least prone to corrosion, isn't it? We know that anode is the most prone to corrosion, and dental amalgam, it is a set dental amalgam is a eutectic material. Eutectic material means there are different phases present in a set amalgam which are not mutually soluble into the solid state. So whenever we mix the dental amalgam alloy with mercury, there's reaction between the alloy powder particles and the mercury, and it results in the formation of different phases in the dental amalgam, like gamma phase, okay, gamma 1, gamma 2, epsilon, like these phases, eta phases. These are the different phases that are formed in the dental amalgam. Now, out of these phases, the question is asking which are the strongest cathodes, the phases that are least prone to corrosion. Option is tin mercury phase. What is tin mercury phase? All of you must be knowing. It is called gamma 2 phase. Gamma 2 phase is most prone to corrosion. Okay. It is the phase that is the weakest phase of dental amalgam. It undergoes corrosion very easily. So it is the strongest anode, not the strongest cathode. So if the question would have been asking what is the strongest anode, anode means oxidation, most prone to corrosion, it would be gamma 2 phase or the tin mercury phase. Copper tin phase is also called epsilon and eta phase, the reaction product of copper with tin. This is a strong phase. It is more stronger as compared to gamma 2 phase. Residual alloy particles. Residual alloy particles, they are called gamma phase. Original alloy particles, the silver tin alloy particles. Isn't it? They are designated as gamma phase, and another reaction product is silver copper phase. Okay, silver copper spherical particles in the high copper alloy. So you should remember that it is the residual alloy particles that are the strongest phases in all form of dental amalgam, whether it is low copper amalgam or high copper amalgam. So the strongest phases are always the residual alloy particles. We know that whenever the alloy particles react with dental mercury, there's formation of different phases, gamma 1, gamma 2, eta, etc. But 100% reaction never occurs, and there are always some residual alloy particles in the set amalgam. And these residual alloy particles, the original alloy particles or the gamma particles, they are the least prone to corrosion. So they would be the strongest cathodes. Okay. So answer would be option C. So instead of these phases, you can be given gamma 1, gamma 2, gamma, etc., epsilon, etc. So do not get confused whether it is high copper or low copper amalgam. Always the residual alloy particles, the original alloy particles, are the strongest cathodes, and they are the least prone to corrosion. Coming over to question number 2. The most common air abrasive used for kinetic tooth preparation is carbide particles, alumina particles, aluminium particles 50 microns, or silicon dioxide particles. Now, what is kinetic cavity preparation? This is also called air abrasion. It is a form of minimal intervention dentistry whenever we want to prepare the cavities with minimum dimensions. Very conservative tooth preparation, especially in the cases of stained pits and fissures. There is no need to use a conventional handpiece and a burr. We can use kinetic cavity preparation by firing the aluminium oxide particles onto the tooth surface. Okay, so definitely answer would be one of the options B or C. Carbide particles are not used. Silicon dioxide particles or silica particles are not used for kinetic cavity preparation. Air abrasion is also called sono abrasion. It is not synonym to air polishing. Okay, so these three terms, first, second, and third, they are synonym. Okay, they represent the same thing: kinetic cavity preparation, sono abrasion, or air abrasion, whereby we use a pressurized stream of aluminium oxide particles for the minimal conservative preparation of the tooth structure. What is air polishing? Air polishing, we use sodium bicarbonate particles, which is used for root planing. After scaling, whenever there are cases of denuded roots, so you must have read it in your perio subject that root planing is done with air polishing. Air polishing, we use sodium bicarbonate particles. So there can be two set of questions like this, one asking about air polishing, one asking about air abrasion. So different particles are used. Now we look at the options B and C. Which is a better option? See, basically speaking, we use aluminium oxide particles in the range of 25 to 30 microns in majority of the cases. It can go up to 50 microns in some cases. The range of particles. So the most suitable option would be option B, that is 25 microns for this. Okay. If we talk about the different other parameters related to kinetic cavity preparation, suppose this is a tooth structure that we need to prepare, then there would be a nozzle from which pressurized aluminium oxide particles, they are fired onto the tooth structure. This nozzle is 0.5 millimeter in diameter. The size of the aluminum oxide particles is this. The pressure is 55 to 80 pounds per square inch or psi. the pressure with which the aluminum oxide particles are fired. The distance from the tip is 3 to 5 millimeters. We never touch the tip to the tooth surface. We hold it 3 to 5 millimeters from the surface in the case of kinetic cavity preparation. Okay. And we use a scanning motion. We do not keep the tip over the tooth stationary or static. We keep on moving it gently in a scanning motion, which is done at the rate of 12 millimeters per second. Okay. And this tip is oriented at an angle of 60 degrees to 90 degrees to the surface. Okay. Maximum cutting is done whenever the tip is held at 90 degrees to the surface. It can be tilted to up to 60 degrees from the surface. The distance is 3 to 5 millimeters. The size of the particles is 25 to 30 microns majorly. The pressure is 55 to 80 pounds per square inch of PSI, and it is moved in a scanning motion from a 0.4 millimeter diameter nozzle. These are the different parameters, technical parameters associated with kinetic cavity preparation, air abrasion, or sono abrasion. Moving over to the next question. Question number 3. The cholesterol crystals are occasionally present in zone of infection, zone of contamination, zone of irritation, or zone of stimulation. We know that you must have read about whenever there is development of a periapical lesion in a tooth, it is divided into 4 zones from inside to outside. They are called fish zones in the case of periapical lesion. Okay. The innermost zone is called zone of infection. Okay. The second zone from inside to outside is called zone of contamination. First zone, the second zone. The third zone from inside to outside, it is called zone of irritation. And we know that as we move away from the infected tooth surface, the intensity of the infection and the virulent microorganism decreases. So there are formation of distinctly different morphological zones in a well-defined periapical lesion. And the fourth zone is zone of stimulation. So all these zones, they are given in the option infection, contamination, irritation, stimulation in the sequence from inside to outside. Now, zone of infection is characterized by, as the name indicates, infection. There would be a lot of bacteria or other microorganisms which cause the periapical lesion. And these bacteria, they would release toxins. And what type of toxins? Normally we encounter 2 type of toxins, endotoxins and exotoxins, isn't it? And it is easy to remember that since we are talking about endodontic periapical lesion, the toxins majority are endotoxins. So this is another question that can be related to this. Okay. Then it also consists of pus cells. A lot of infection is there. It consists of even dead cellular material. Zone of infection, the innermost zone. The second zone from inside to outside is zone of acute inflammation. Zone of acute inflammation. And we know that what are the cells typical of acute inflammation? They are polymorphonuclear neutrophils. So these are the major cellular elements present in the zone of contamination. The zone of irritation is the third zone from inside to outside. It is called zone of chronic inflammation. Zone of chronic inflammation. Now, what are the chronic inflammatory cells? They are the plasma cells, histiocytes. Okay. These are the common plasma cells, histiocytes, lymphocytes. All these are chronic inflammatory cells. And along with the chronic inflammatory cell, one typical thing is present, that is cholesterol crystals. These cholesterol crystals, they are immunogenic. They can generate a immune response whenever the formation of cholesterol crystals takes place. So the question is asking, in which zone of periapical lesion? The answer would be zone of irritation. That is the third zone from inside to outside. Option C would be the answer, zone of irritation or zone of chronic inflammation. Okay. These cholesterol crystals, when present in large amounts in the periapical lesion, so a periapical lesion that is divided into zones, a well differentiated periapical lesion that is divided into zones and consists of numerous cholesterol crystals in the zone of irritation, they are called cholesteatoma. Cholesteatoma. So what is the term cholesteatoma indicated? The cholesteatoma indicates a periapical lesion that consists of numerous cholesterol crystals or majority of cholesterol crystals in the zone of irritation. And finally, the zone of stimulation. As the name indicates, the infection is very less in this zone. So instead of causing any damage, it stimulates the tissue. We always know that the low grade infection, just like we get stimulation of the immunity by having a vaccine. So what is a vaccine? Basically, a very subtle or low dose of infection is given and the body reacts by stimulating. So similar thing happens. There is stimulation. So there is neocollagenous formation and neoangiogenesis. Angiogenesis means formation of new blood vessels, etc. happens in the zone of stimulation. So these are the typical zones present in a well-defined periapical lesion. They are divided and called as fish zones and their respective characteristics. Coming over to next question. Question number 4 as displayed onto your screens. The most efficient laser for cutting and drilling enamel and dentine is, I think all must be able to answer this. A straightforward question. Enamel and dentine, what type of tissues they are? They are dental hard tissues. So two type of tissues we encounter in the oral cavity. One are the soft tissues, another the hard tissues. So we have to basically look for hard tissue laser. Now what are the hard tissue lasers? Erbium YAG, carbon dioxide, KTP and NdF. A, C and D, they are mostly used for soft tissue cutting. Erbium YAG laser, it is the hard tissue laser. So answer would be option B. Always remember that two type of lasers act on dental hard tissues. One are the excimer lasers, another are the erbium lasers. Two set of tissues are used for dental hard tissues. What are excimer lasers? They are special ultraviolet lasers. Excimer lasers like argon fluoride, krypton fluoride, xenon chloride. Okay, they are also suitable for cutting the dental hard tissues, whether it is enamel, dentine, cementum, or at times even bone also they can act upon, whatever calcified tissues are there. Erbium lasers, if we talk about, there are two erbium lasers prominent, the erbium YAG laser and erbium chromium YSGG laser. Okay, this erbium chromium YSGG is also called water lace. Waterlays. Waterlays means we know that the hard tissues like enamel, dentin, and cementum, they are made up of hydroxyapatite crystals. And these hydroxyapatite crystals, they are hydrophilic. They contain a lot of water molecules bound to them. When we use waterlays, the energy of the laser is absorbed by the water particles. They explode and they fracture the hydroxyapatite. This is the method of cutting the tooth structure with the waterlays. And if we talk about the wavelength, it has a wavelength of 2940 nanometers. Sorry, 2790 nanometers. Erbium X 2940 nanometers respective wavelength. So another common question that is asked is about the wavelength of these lasers. If we talk about argon fluoride, 198 nanometers, krypton fluoride 204 nanometers, and xenon chloride is 308 nanometers. We all know that ultraviolet is the spectrum. Ultraviolet, then there are visible, and then there are infrared lasers depending upon the wavelength of light. Visible is in the range of 400 to 700 nanometers. Above than that is infrared, and less than that is ultraviolet. Okay. We know that all these wavelengths, they are less than 400 nanometers. These wavelengths are more than 400 and 700 nanometers. So basically RBM YAG lasers, they are infrared lasers, and these are ultraviolet lasers. And always remember, out of these two type of tissue lasers, erbium lasers, they are the most efficient in cutting dental hard tissues, whether it is enamel, dentin, or cementum. So always would be the first choice answer for hard tissues. Coming over to next question. Question number 5. The pain from teeth is referred to adjacent mucosa and other teeth. Such pain is mediated by what? The patient is complaining of pain on one particular tooth, and it is radiated to the soft tissues in the adjacent tooth. A delta fibers, A beta fibers, C fibers, or the gamma fibers. Now, pulpal pain can be mediated by these three fibers: A delta, A beta, and C fibers. Okay, A delta fibers, they constitute about 90% of A fibers. A beta fibers, they are 10% of A fibers. Together, they constitute about 20% of sensory nerve fibers in the dental pulp. And if we talk about the C fibers, they are 80% of sensory nerve fibers. Okay, so if this is a dental pulp of a tooth, then in the periphery there would be A delta fibers, and in the center there would be C fibers. This is the distribution and morphological orientation of A delta and C fibers. A beta fibers are very less, just 10% of the 20% sensory fibers. Okay, and the type of sensations which these fibers carry. A delta fibers, they carry the sensation of pain, temperature, and touch. A beta fibers, they carry the sensation of proprioception. What is proprioception? Pressure reception. So whenever we talk about tenderness on percussion, so tenderness on percussion happens because of A beta fibers proprioception. Now the periodontal ligament around the teeth is very rich in A beta fibers. So whenever there is some sort of apical periodontitis or inflammation of the PDL, the slightest of the pressure on the tooth gives pain to the patient. So pain on pressure or tenderness on percussion may indicates there is a stimulation of proprioceptors or the A beta fibers. The C fibers, they carry the sensation of only the pain Okay, and since these C fibers, they are present in maximum number in the dental pulp, oriented in the centrally located, they are called principal nociceptors. What are nociceptors? Pain receptors are called nociceptors. So definitely a tooth that is grossly inflamed, a pulp that is grossly inflamed would be having lot of inflamed C fibers. These C fibers, okay, cause pain only not into the tooth only, but because of lot of cross innervation between the teeth is there. So adjacent teeth also feel pain as well as the soft tissues. So answer would be C fibers. And also remember that these C fibers are very resistant to hypoxia. Hypoxia means whenever there is infected pulp, the oxygen supply is reduced. The A delta fibers would be the first, or the A group of fibers would be the first to get degenerated. And C fibers, they are resistant to hypoxia. So even in cases of necrotic pulp, if at all there is pain to the patient, it would be because of these C fibers. So option C, that is the C fiber, would be the answer here. Question number 6. Another one of the common questions related to endodontic instrumentation. They would show you the cross section and the generation division we have already seen in the previous sessions. Another question related to that. What generation of nickel titanium file is represented by the below cross section? First, second, third, or fourth? I think it should be very easy to answer if you know the generations. We see that there are blunted blades with radial lens. There are blunted blades with radial lens. So they are the first generation or the passive cutting instruments. Option A would be the answer. Second generation, we have seen it in the previous session also. There would be active cutting without radial lens, isn't it? So they would be having cross section something like this. There would be no radial lens in the blades of the file. Third generation, they have got some sort of heat treatment that improves the cutting efficiency and flexibility of the instrument, special heat treated instruments. Fourth generation, they have got alternate motions of use like up and down. It is just a quick revision of whatever we have seen in the previous sessions, or it can be reciprocation. Okay, and finally the fifth generation, they have got offset design. Offset design with rectangular cross section. So they would be having a cross section with offset design, means the center of rotation does not coincide with the center of the instrument axis. Axis of rotation is different from the center of the instrument. Offset design. These are the 5 generations. The cross section given one is sometimes also called U-shaped cross section. You can see it is like a U, isn't it? It is called U-shaped cross section. Option A would be the answer over here. Question number 7. All are true about instruments except the instrument is shown in the figure. All are true about this instrument except it is used for post-space preparation. It is having a cutting and non-cutting tip. It is used in the speed range of 2000 to 2500 RPM, and it is used in a straight portion of the root canal, which is incorrect. To answer this, firstly, you have to identify the instrument. I think there should be no difficulty in identifying it. It is a Piezo reamer. Piezo reamer, isn't it? This piezo reamer is used for post space preparation. The only documented use of this instrument is for post space preparation. Okay. This piezo reamer is mostly made up of stainless steel instrument, and this instrument can have both cutting and non-cutting tip. Okay, instrument with non-cutting tip is sometimes also called bat tip. Bat tip. So, non-cutting tip of an instrument is also called bat tip. It is used for post-space preparation. Option A is correct. It can have both cutting and non-cutting tips. Option B is also correct. It is a low-speed engine-driven instrument. We all know about the classification of instruments into groups as given by ISO. Principally, 6 groups are there. So these piezo reamers, along with GG drills, they are placed under Group 2. So they are Group 2 low-speed engine-driven instruments. Low speed means they are used in the speed range of 750 to 1500 RPM. Option C says in the range of 2000 to 2500 RPM is incorrect. Look at the option number D. It is used in straight portion of the root canal is also correct. Piezo reamers, they are stainless steel stiff instruments. Okay, they should always be used in the straight portions of the root canals along with another instrument, that is GG drill. So option A, B and D are correct. C is incorrect. So would be the answer over here. What is the speed range? This. And if we all talk about the sizes of these instruments, they are number 1 through number 6. The only difference in the tip diameter of the instrument. Number 1 is a tip diameter of 0.7 millimeters. Number 2, 0.9 millimeters. Number 3, 1.1 millimeter. Number 4, 1.3 millimeter. And number 5, 1.5 millimeter. Finally, number 6 would be 1.7 millimeter. So this is the range in size in which the instruments number 1 through 6, that is called piezo reamers, are available. They are low speed engine driven instruments used for post space preparation. Okay. And you can see there is increment of 0.2 millimeter between each successive instrument. Okay, these are some of the important points related to your Group 2 low speed engine driven instruments called piezo reamers. Question number 8 as displayed onto your screens. All are true for the above instrument except, I think you can easily identify when the name of the instrument is given there. It is obtura. Okay, what is obtura? It is a high heat. It is a high heat thermoplastic obturation. Thermoplastic obturation device. We know thermoplasticized gutta percha obturation means direct injection of liquid gutta percha inside the root canals. So all are true except it heats the gutta percha to the temperature of 90 degrees Celsius. The temperature of the extruded gutta percha is 71 degrees Celsius. It is used mostly for the backfilling of the root canals, and the poor length control is the main disadvantage of this instrument. Now basically asking about thermoplastic obturation system. Okay, high heat technique means this is a gun-like device as can be seen in the figure, and it heats the gutta percha to 160 degrees Celsius. And when we press the trigger, the liquid gutta percha comes out inside the root canal, and this immediately cools down to the temperature of 71 to 72 degrees Celsius. So there are two set of temperatures that you remember, that how much it is heated, 160 degrees Celsius. It can be a range also, 160 to 200 degrees Celsius. If only one option, 160 degrees Celsius. If range, up to 200. Okay. And what is the temperature of the gut temperature that is extruded? It immediately cools down to 71 to 72 degrees Celsius. That is safe for the tolerance of the tissues like the dental hard tissues, PDL, and the other soft tissues. So if we look at option number A, definitely it is incorrect. The temperature is heated to not 90 but 160 degrees Celsius. The temperature of the extruded gut temperature 71 is correct. It is used mostly for backfilling of the root canals. Yes, what is backfilling? Means if this is the root canal, okay, the apical 1/3 of the root canal is first obturated with your gut temperature cone or any other semi-solid or solid form of gut temperature. Okay, and then the middle to coronal 1/3 of the root canal is filled with your thermoplastic obturation material. Okay, so this is called backfilling of the root canal. So it is mostly used for backfilling, true. And poor length control is the main disadvantage, is also correct. That whenever we are injecting liquid gut temperature inside the root canal, how much of it would penetrate to what depth cannot be accurately controlled by the clinician. So poor length control, it can be either short or it can go beyond the apex, is the main disadvantage of not only Obtura but all forms of thermoplastic obturation devices. So B, C, and D, they are correct. What is not correct? Option A. It would be the answer over here for Obtura. What is 90 degrees Celsius heating? It is for ultrafill. The device, another device that is commercially available for thermoplastic obturation is ultrafill. It heats the gut temperature to 90 degrees Celsius. It is called low heat technique. So whenever we talk about thermoplastic obturation, the devices that are principally used are high heat technique devices, that is Obtura, the low heat technique device, that is ultrafill, and variable heat techniques. The third type of devices, first one are the high heat, low heat. The third one, they are the variable heat methods. Different commercially available devices, variable heat methods. Okay, they include calamus, hot shot, and elements. Numerous other devices are available in the market, but these 5 are the principal ones. 2 are specifically as low and high heat and their respective temperatures. Variable heat means the temperature is not fixed. It can vary from situation to situation. Okay. Coming over to question number 9. The following does not assist in locating the root canal orifices. Following does not assist in locating root canal orifice: hydrogen peroxide, sodium hypochlorite, DG16, and the dent panel map. I think there should be no difficulty in answering this. Okay. Sodium hypochlorite is used. DG16 is the endodontic explorer. It is the endodontic explorer. Okay, something with fine tips. There's a handle. And it has got very sharp tips for locating the root canal orifice. Hydrogen peroxide is not used. Sodium hypochlorite is used in what is called as champagne bubble test. Champagne bubble test. The use of sodium hypochlorite. What is done? We have to locate supposed root canal orifice in a tooth into which excess cavity has been prepared. Okay, these are the pulp canals of the tooth, and we have to locate the orifice which are not visible initially. We would clean the pulp chamber in the first step. This cleaning of pulp chamber is done with a combination of 17% EDTA plus 95% ethanol. Another question that has come: how do we clean the pulp chamber to visualize the orifices? Okay, then after this, the second step in the clean pulp chamber, we flood it with sodium hypochlorite. Now, sodium hypochlorite is a very low surface tension fluid which is colorless, clear, and transparent. So whenever it comes into contact with the organic tissue like pulp at the orifice, so it would give a stream of bubbles emanating from the surface. A clear streak of bubbles would come at respective locations where it comes in contact with the dental pulp, because it liberates chlorine and there is degeneration and liberation of bubbles. So this is called champagne bubble test. We can clearly see from which point in the floor of the pulp chamber the bubbles are coming up, and that respective points we can probe with an endodontic explorer like DG16 to locate the root canal orifice. And what is dentinal map? If we look at the floor of the pulp chamber, there is a series of grooves which connect the different root canal orifice. Okay, and they constitute a map that is called dentinal map. And if you remember that Kressner and Renko gave the principles for root canal access preparation and principles for root canal orifice location. In that, one of the rules is that root canal orifice are located at the termination of root developmental grooves. So we would trace the groove, and wherever it ends, there would be a root canal orifice. So in the floor of the pulp chamber, the various root canal orifices are connected by a series of grooves that constitute a map called dentinal map. So it is also helpful, a visual aid in detecting the root canal orifice. Hydrogen peroxide is not used, would be the answer over here. Question number 10. EPT does not give false positive result in patients with false positive. False positive, you should know that it has got low specificity. It is not specific. Okay. So false positive results means although the pulp is degenerated and necrotic, the patient would complain of pain when electric pulp tester is attached to it and current is flown. So aspirin one day before. If the patient is taking aspirin or any other analgesic, the patient would be sedated. Okay. And he would not respond to electric pulp tester. So it would be a false negative situation. Not false positive. If we look at anxiety, a patient who is anxious and apprehensive would feel pain always, even though when there is no physical pain. Even at the site of the instrument, the site of the electric pulp tester can make the patient flinch and the patient can feel psychological pain. So anxiety can give definitely false positive. Liquefied pulpal necrosis. Although the pulp is necrotic due to presence of various salts, the current would be conducted to the healthy periapical tissues, and this would also give you a false positive response. Isn't it? Multi-rooted teeth like maxillary and mandibular molars, the pulp can be vital in some of the portions of the roots. Majority of the pulp is degenerated. But those viable nerve fibers present in the vital pulp stumps can conduct the current and give sensation of pain to the patient, although the pulp is majorly degenerated and RCT is required. So again, this can give you a false positive situation. So, which is not giving you false positive? Any analgesic taken, drugs taken, alcohol taken would give you a false negative. There would be no response because the patient's nerves are numbed, the pain threshold is increased, so there would be a false negative response. So answer would be option A. Question number 11. One of the following will not have major effect on the tooth discoloration following amalgam restoration. Will not have major effect. Adequate condensation, void in the restoration, cavity extending to involve the root, and burnishing of amalgam along the cavo surface margins. This is regarding the manipulation of dental amalgam, which will not have a major effect on tooth discoloration. Now, tooth discoloration, they are called amalgam blues. Okay. Whenever a tooth is having amalgam restoration, there is bluish discoloration of the tooth due to seepage of mercury and other metals into the dentinal tubules. Into the dentinal tubules. And they would give a bluish hue or discoloration called amalgam blues. On the contrary, what is amalgam tattoo? What are amalgam tattoos? Amalgam tattoos are soft tissue discoloration. The adjacent mucosa in the soft tissues that come in contact with the dental amalgam can give a bluish discoloration that is called amalgam tattoo, and amalgam blues are discoloration of the teeth. Now, these are the two terms which are different. Now, adequate condensation of the amalgam. Okay. Whenever we condense the amalgam adequately, there are chances that due to pressure of condensation, some of the amalgam that is initially soft, some of the mercury that is present in the initial unset amalgam during condensation can be dispersed into the dentinal tubules based upon the pressure of condensation. So definitely condensation is a factor that would affect the potential for tooth discoloration. Voids in the restoration. Suppose this is a tooth and this is the amalgam restoration. If this amalgam restoration has got voids, they would not affect the tooth discoloration. They would decrease the strength of amalgam. Isn't it? An amalgam that is not properly condensed is having voids, would be having poor strength as compared to a properly condensed amalgam, but it would not significantly affect the potential for tooth discoloration. Okay, so this can be an answer. Look at other options. Cavity extending to involve the root. Okay, definitely whenever the cavity is extending to involve the root, there are more potential of discoloration because cementum is a softer tissue as compared to enamel and dentine, and it is more likely to be discolored. So this will also affect burnishing of amalgam along the cavo surface margins. Okay, what are cavo surface margins? Suppose we look at the restoration from above. This is the amalgam restoration, and these are the cavo surface margins. If there is gap between the amalgam and the cavo surface margins, then there would be seepage of materials and would result in discoloration of the tooth structure. So this also has a factor that influences. So the factor that is least likely, it can influence discoloration, but least likely is option B, presence of voids in the restoration. Voids would mostly affect the strength of amalgam, not the potential for discoloration. Question number 12. The pulp will undergo necrosis most rapidly in some sort of injuries are given: avulsion, intrusion, extrusion, and subluxation. Now we have to talk about pulp necrosis, and it is easy to answer. The injury that is the most severe form of injury would give result to necrosis rapidly. So out of these injuries, these are the luxation injuries and avulsion means complete exarticulation of the tooth. So when the tooth comes out completely from the socket, there would be definitely complete severage of the neurovascular bundle, and necrosis of the tooth most rapidly happens over here. Option A. If suppose avulsion was not there in the options, then what would be the best? If only luxation injuries are listed, intrusion. It is the most severe form of luxation injury. So avulsion always would have the pulp necrosis occurs in 100% cases of avulsion. There is no exception, more likely than intrusion. So if avulsion is not there, intrusion would be the answer. But since avulsion is there in the options, option A would be the answer over here. Okay. Avulsion. 100% pulpal necrosis would occur in cases of avulsion. Coming over to question number 13. In an endodontically treated tooth, the reduction in strength due to loss of moisture and collagen fiber rearrangement is 5%, 14%, 60%, and 21%. Now, this is something that you have to remember, that whenever we do root canal treatment of a tooth, there are certain changes in the structural organization of the tooth, like loss of moisture. So the loss of moisture happens 9%. Okay. The question is asking the factors loss of moisture and collagen fiber rearrangement contribute to how much reduction in the flexural strength of tooth. Answer would be 14%. Option B. If the question is asking how much simply loss of moisture is there, answer would be 9%. And it is the free water that is lost. The bound water is not lost. Hydroxyapatite, which forms the structure of enamel and dentine, it consists of both free water bound to it and bound water. Free water present between the crystals, bound water attached to the crystals. So how much is loss of moisture? It is 9%. And what type of moisture is lost? It is the free water that is lost. Another thing happens that there is rearrangement of collagen fibers, especially in cases of dentine. We know that significant collagen fibers are present in dentine. So these two together contribute 14% reduction of strength. 5% reduction of strength is with a class 1 excess cavity preparation. With a class 1 excess cavity preparation. What is a class 1 excess cavity preparation? Any preparation for root canal that is centered in the tooth with all the walls intact is called class 1 cavity preparation. 60% reduction happens whenever we make a MOD preparation. When both the marginal ridges of the tooth are involved in the root canal or destroyed due to caries, then maximum reduction of the tooth flexural strength happens. That's 60%. This also answers that Then endodontically treated tooth is considered to be brittle. Why it is brittle? It is brittle because not loss of moisture or collagen fiber rearrangement. It becomes brittle and susceptible to fracture due to loss of coronal tooth structure. So we should preserve as much of the tooth structure as possible to preserve the strength of an endodontically treated tooth. Maximum reduction happens with a MOD preparation. Coming over to next question, question number 14. The below device is used for the administration of local anesthesia, irrigation of the root canal with positive pressure, irrigation of the root canal with negative pressure, or pulp testing with cold water. To answer this, you have to identify the device, and if you remember, then it is one of the device for irrigation of the root canal. This is called safety irrigator. This device is safety irrigator and it works upon positive pressure irrigation. Positive pressure irrigation and evacuation. Simultaneous irrigation evacuation device is called safety irrigator. So definitely answer would be option number B. What would be the options for irrigation with root canal with negative pressure? Two examples you can remember: endovac and rinse endo. Okay. Endovac and rinse endo are negative pressure irrigation systems. Safety irrigator shown above is a positive pressure irrigation system. All three have one thing in common. They do simultaneous irrigation and evacuation of the root canal. You can see the fluid comes out of here and it is taken out the root canal from here. So simultaneous irrigation and evacuation. This vent is for irrigation. This is for evacuation. So there is a continuously flowing fluid inside the root canals and being taken out through the pulp chamber. Safety irrigator. Coming over to the last question for today's session. The below radiograph depicts the following procedure. You can see there is a tooth with periapical lesion and some instrument is being inserted and that is going through the periapical tissues. Okay. Orthogrid periapical debridement. It is a separated instrument retrieval, working length determination, or post space preparation. What is this? Definitely, this is not something called Peeso reamer, so no post space preparation is being done. Working length determination, again not there. Separated instrument retrieval, it can look like a microtube removal method because there is a microtube. Okay. So there are microtubes available for removing the separated instrument, but you can see there's a typical anatomy called bent instrument tip. This is least likely to happen with a separated instrument, even though the part of it goes into the periapical tissues. So a separated instrument would be something like this. Even if it is slightly curved, it can be something that is like this, but definitely not typical J-shaped curvature. This is what this is a PEXUM device. So this radiograph shows an attempt for orthogrid, means through the root canal debridement of the periapical lesion in a non-surgical manner by using a PEXUM device. A PEXUM device, it is based upon nickel titanium. Two things are there. This is a microtube made up of nickel titanium, and this is a nickel titanium ablator. Okay. So when This nickel titanium ablator is passed through the microtube into the periapical tissues. Because of its shape memory, it assumes a bent shape and then it is rotated. So it mixes and minces the periapical lesion like a blade of a mixer, and it can be then flushed copiously to drain it out from the root canals. So this is a device called Apexum device. It is a nickel titanium device for orthograde periapical debridement of the periapical lesion without surgery. Option A would be the answer. Okay, you can clearly identify the typical acute bend of the nickel titanium ablator. Okay. These nickel titanium ablator are of two types, fine and coarse, which are rotated inside the root canals. Fine is rotated at 7000 rpm and coarse is rotated at 250 rpm, and both are done for 30 seconds rotation for periapical debridement through the root canals. First we use a coarse, second we use the fine ablator. These are the other things related to the Apexum device. Okay. That is all for today's PYQs. All these have been the important questions that have come in the previous examinations. With this, I conclude today's session. I hope it has been comprehensive enough for you guys. See you again in some other interesting session related to my subject. Till then, happy reading. Take care, everyone. Good night from my side. Thank you very much for being connected.